Hello everyone and welcome back to Clinical Cousins YouTube channel, where today we're going to go over how our body quickly changes our mean arterial pressure, our MAP, by using special sensors and nerve systems that collectively we call the baroreceptor reflex. Now, what are baroreceptors? Well, baroreceptors are simply receptors that respond to pressure. So we have these baroreceptors in our carotid sinus and our aortic arch. Now, the carotid sinus is just before the carotid arteries bifurcate into two branches. So the carotid sinus would be right here in the palm of my hand, sort of. So these receptors, they respond to changes in our mean arterial pressure. Now, if you don't know what that is, go back and watch our video on that and then come back to this one. But we know the mean arterial pressure is the average blood pressure. So 2/3 diastolic plus 1/3 systolic. So these baroreceptors, they have a certain pressure that they like, a certain set point, and they're going to use this set point to determine whether or not they need to freak out and tell our brain that something is wrong, or if nothing's wrong and everything's okay. So basically, let's just say that the mean arterial pressure set point is about 100 millimeters of mercury. And I'm going to say just numbers, but just know that I'm talking about millimeters of mercury. So for this particular patient, their MAP is around 100. This is their set point. Well, the baroreceptors are like buttons that are being pushed at a constant rate. And whenever we increase the MAP, the button gets pushed really, really fast. It's going to send a signal via afferent neurons to our brain to decrease that pressure back to that MAP that our baroreceptors like. Now, when the MAP falls below the set point, the button doesn't get pushed at all, or it might just be decreased, right? So the baroreceptors are going to send less messages to our brain, and our brain is going to freak out, and it's going to do everything that it can so that it can raise that pressure up back to that nice 100 set point that we were talking about. So it should be mentioned that in some cases, like chronic uncontrolled hypertension, meaning hypertension over a long period of time that's not controlled with medications, the baroreceptors can actually get used to a higher MAP. So this might be their set point. Let's say it's around 120. Now, this is actually a bad thing, because now our baroreceptor system is going to want to maintain that 120. Now, if the MAP falls below, say to a normal pressure of around 100, maybe we like this because this is a good blood pressure for the rest of our organs. But the baroreceptors are not used to this. They are not being pushed enough, and they are going to tell the brain to raise this pressure because they are uncomfortable. So basically, the brain is going to fight us, and it is going to try to raise that set point back to that 120. So before we go over some scenarios with our patient today, it's important to know that the carotid sinus baroreceptors in the neck, they rely on the carotid sinus nerve and the glossopharyngeal nerve. Now, how I like to remember this is that glossopharyngeal, glosso meaning tongue, that kind of looks like a tongue. This kind of looks like a throat. So glossopharyngeal, cranial nerve 9. Now, the carotid baroreceptors are going to use cranial nerve 9, but the aortic arch baroreceptors are going to use cranial nerve 10. Now, what's special about that one? It's arguably one of our most important. It's the vagus nerve, and it's going to carry messages to the brain. Now, the part of the brain that regulates our blood pressure is called the pons and medulla. So collectively, we like to say that they're part of the brain stem. Now, the brain stem houses some of our most basic functions, so it makes sense that blood pressure is one of these functions. The lower third of the pons is our vasoconstrictor center. Below that, we have a cardiac accelerator center. This is the gas. Now, below that, we have a cardiac decelerator center, and this is our brakes. Now, the vasoconstrictive center, its entire job in its life is to clamp down our arterioles, clamp down our blood vessels to raise our MAP. Now, the cardiac accelerator center, its whole purpose is to increase our heart rate and contractility, to make our heart squeeze hard and fast. Now, lastly, our cardiac decelerator center, it's the brakes. It's going to decrease our heart rate and our contractility to an extent. Now, the pathway goes like this. Our carotid sinus and aortic arch baroreceptors are going to use cranial nerve 9 and cranial nerve 10 to relay information to a special part of our brain that we like to call the nucleus tractus solitarius, or NTS. Now, the NTS is going to pass this information to these three blood pressure centers, which we just talked about, and they're going to collaborate and work together, and they're going to come up with the solution to the problem. So they're going to actually send efferent nerves going out of the brain, right? The efferent nerves are going to come from the blood pressure centers, and then they're either going to use sympathetic or parasympathetic nerves to alter our heart rate, contractility, and TPR in order to maintain our blood pressure as close to that nice set point as possible. So, well, what happens when we have too much pressure? Let's say that we've overloaded our patient with way too much fluids, and we've given them salty Gatorade to drink, and we've stressed them out. We've given them an exam to do while they're in the hospital. Well, their MAP is going to be sky high. Well, what happens when our MAP is sky high? How does our body regulate that? Well, our carotid and aortic baroreceptors are going to send too many signals via cranial nerves 9 and 10, and they're going to pass this to the NTS. Now, the NTS is going to tell our 3 blood pressure centers what the situation is. So the NTS is going to say, listen guys, our MAP is too high. So the blood pressure centers, they're going to get together and they're going to say, okay, let's lower the pressure. So the vasoconstrictor center is going to be inhibited. The cardiac accelerator center is going to be inhibited. And the cardiac decelerator center is going to be activated. This is our brakes, right? We're going too fast. The cardiac decelerator center is going to be our brakes. So it's going to use a parasympathetic nerve, specifically the vagus nerve, and it's going to synapse on the SA node of the heart. Now, the vagus nerve, it releases acetylcholine, and it's going to release this ACH onto a channel which is conveniently called acetylcholine potassium channel. Now, potassium is going to flood out of the cell, and it's going to make our SA node more sleepy, more negative, more lazy, however you want to say it. It's going to decrease our heart rate. Our vagus nerve is going to decrease our heart rate. Now, these 3 actions are going to help decrease our cardiac output, decrease our TPR. In an overall sense, they are going to decrease our blood pressure, our MAP, to get it back to that set point, to get it back to baseline where our body likes it. Now, let's see what happens when we look at the opposite scenario, when we have a drop in our MAP. So let's say that somebody stabbed us and we're hemorrhaging blood, or we've been partying all night, we're out in the desert, whatever you want to say, we don't have enough pressure. Well, these baroreceptor buttons are not going to be getting pushed enough. They're going to send messages via cranial nerves 9 and 10 to the NTS to say, listen, our pressure is low. The NTS is going to pass along this information to the blood pressure centers who want to raise the MAP. They're going to get together and say, listen, we got to bring this pressure back up or else this is game over. So the vasoconstrictor center is going to be activated, and it's going to use sympathetic nerves to release norepinephrine onto our alpha-1 receptors. So this is what really clamps down our vessels. Now, at the same time, the cardiac accelerator center is activated, and it's going to use its own sympathetic nerves to release norepinephrine onto beta-1 receptors of the heart. So these are very, very popular, very, very important receptors. It's likely that your patient's going to be on some sort of medication that alters these receptors. So we know from our previous videos in the scissor acronym, beta-1 is speed up. So we know that beta-1 receptors, more calcium, the SA node is going to send impulses faster. The AV node is going to conduct these impulses faster, and the ventricles are going to contract with more strength. They're going to have greater contractility. So while all this is happening, the cardiac decelerator center is going to inhibit itself. This will actually enhance our sympathetic effects. So all of these actions, they work together to increase our cardiac output, to increase our TPR. These actions work together to raise our MAP back up to that nice set point that our body likes. Well, what happens when we have an increase in MAP? Very simply, an increase in MAP means that our baroreceptors are going to detect this. They're going to tell our blood pressure centers, and then our blood pressure centers are going to work together to bring our MAP back down to that normal set point. Now, what happens when our MAP falls below the set point? Well, our baroreceptors are going to tell our blood pressure centers that our MAP is too low, and they're going to do everything they can to bring it back up. Now, how can this be useful in our actual practice? Well, it can definitely work against us. Now, oftentimes our patients that come in with hypertension, they need to have their blood pressure lowered to decrease the risk of coronary events like a heart attack or a stroke or anything that involves hypertension. So what we do is we give them drugs like ACE inhibitors, drugs like diltiazem, verapamil, any calcium channel blocker, anything that has to do with the renin-angiotensin-aldosterone system, anything that has to do with alpha 2 receptors like clonidine especially, all these drugs that we're going to give them, they're going to lower that MAP. Now you're going to say, wait, well, this is a good thing. We're lowering the blood pressure. The body should like that. The body doesn't. The body, for years probably, has been used to getting that high amount of blood pressure. So when we lower it, say to a good number to us, the body does not like that. So their baroreceptors, the patient's baroreceptors are so used to having that they're going to think that they're hemorrhaging, that it's almost game over. So their brain is going to do everything that it can to increase that MAP. Well, what is it going to do? This is what we call rebound tachycardia and rebound hypertension. So what happens is the cardiac accelerator centers and vasoconstrictor centers, they're going to constrict our vessels, hypertension, and they're going to increase our heart rate, tachycardia. So this is why you're often going to see beta blockers and other drugs that counteract these reflex effects, right? These reflex effects of vasoconstriction and tachycardia given alongside our vasodilators, our ACE inhibitors, ARBs, our calcium channel blockers. We're going to be giving drugs like beta blockers, which will blunt these effects so that our patient can have a normal, healthy blood pressure and that their body can actually get used to that new set point. So as always, thank you for taking the time to learn with us today, and I hope you like and subscribe for more content. Thank you.